In this presentation, we will be discussing some common neck back complaints that you will see in primary care, including back pain, joint pain, osteoarthritis, plantar fasciitis, and carpal tunnel syndrome. My name is Dr. Tolu Ajay. I am a board-certified FNP, and I currently practice at the Mayo Clinic Occupational Medicine Department. I am also a visiting professor with Chamberlain University. Pain and limited range of motion arising from structures in the back and neck are common complaints. Pain may originate from any of the musculoskeletal structures, which include muscle, ligament, tendons, cervical vertebrae, nerves, and vasculature. Looking at the spine anatomy itself, we can see that the spine consists of cervical, 7 vertebrae, thoracic, 12 vertebrae, lumbar, 5 vertebrae, sacrum, 5 segments, and coccyx, 4 fused segments. Neck pain history. Let's start by discussing neck pain. The causes of neck pain are generally structural in nature and most often are the result of trauma, degenerative changes, or muscle spasms. Contributing factors can include stress, mechanical injury, and sedentary occupations. Normal posture should be effortless and painless. Abnormal forward posture of the head can result in chronic strain on the posterior muscle of the neck. Common activities that contribute to abnormal posture are use of computers with screen below eye level and improper posture. When taking a history and review of systems, several important questions should be asked, such as onset. Is it acute or gradual? Was there an inciting event or injury? Location. Does the neck pain include the arm, shoulder, head, or lower spine? Duration. Is the pain constant or intermittent? Does it wax or wane in intensity? Character. Is the pain dull, sharp, or aching? Is the pain radicular, that is, travel in a dermatome pattern, or radiate? Aggravating. Does anything make the pain worse? Relieving. Does anything make the pain better? Treatment. What treatments have been tried, such as medications, conservative, or holistic therapy? Severity. Pain and limitation on activities of daily living. Previous injuries to the back or neck. Occupation, recreational activities, and hobbies. Neck pain physical exam. Physical exam of the neck should include the following: range of motion of the neck, including flexion, extension, and rotation to determine limitation and reproduction of pain. Palpation of the neck to assess for tenderness and muscle spasms. Palpation of lymph nodes to determine enlarged lymph nodes in the absence of infection can indicate malignancy. Evaluation of the vascular structures and thyroid. Muscle strength of the extremity, including deltoid, biceps, tricep, wrist, fingers, and hand grasp. Sensation should be assessed, paying attention to dermatome patterns, as this may indicate nerve root compression. Also, deep tendon reflexes. Cervical strain or sprain. This is a muscle injury in the neck that can include ligamentous or stretching type injuries. ligamentous injuries of facet joints and/or intervertebral disc. As I said earlier, poor posture or direct injury can cause neck pain. This is the result of cervical muscle fibers being over-elongated, which produces edema and microhemorrhaging. The response of the muscle and the surrounding muscle is to contract, which results in increased tone and the inability of the muscle to relax or spasm. A common cause of traumatic neck pain from an injury is that which occurs following a motor vehicle accident. In rare impact collisions, the driver is usually relaxed and unaware of the impending collision. An acceleration-deceleration injury results from cervical hyperextension. The driver is often unaware of the injury, but later will start to develop stiffness in the neck. Pain usually develops within 24 hours of the injury. Symptoms of cervical strain are the following. Non-focal pain is usually in the middle of the lower part of the posterior neck. Pain may radiate towards the shoulder, as in the case of a strain involving trapezius muscle, but does not travel down to the arm. Non-radicular does not follow the nerve root or dermatome pattern. Pain is worse with movement, paraspinal spasm, and occipital headaches. Imaging: plain cervical spine films may reveal a straightening of the lordotic curvature or may be normal. Patients involved in motor vehicle accidents who have neck pain and point tenderness should have plain films to rule out fracture or dislocation, followed by flexion-extension films to evaluate for an anterior longitudinal ligament or a posterior longitudinal injury. This type of injury may cause a shift in the vertebrae due to lack of support, which may result in direct cervical cord damage. Any evidence of neurological deficit warrants further testing with EMG and nerve conduction studies or MRI to determine the cause. Neck pain differential diagnosis. The diagnosis of cervical muscle strain is based on the history and physical exam revealing localized neck pain, cervical sprain, muscle spasms, and normal neurological exam. The differential should include the following: cervical disc herniation will see radicular pain and neurological abnormality. Cervical spine tumor, usually accompanied by systemic symptoms such as weight loss, along with neurological deficit. Cervical spine infection, accompanied by fever, chills, and elevated WBC and ESR. Dislocation, subluxation, or fracture would be seen on radiograph. Inflammatory conditions of the cervical spine, as seen in RA, will also be evident on imaging. Neck pain treatment. Early mobilization has been shown to improve pain and facilitate return to full function compared to rest and prolonged use of cervical collar. A soft cervical collar for support can be worn after a motor vehicle accident for 2 to 3 hours, at a time for no more than 3 days. A decrease in activity allows the injured tissue to heal. However, overuse will result in prolonged stiffness. Insects, acetaminophen, and muscle relaxants may be beneficial and topical NSAIDs, especially topical ketoprofen or diclofenac gel, have been shown to be effective in randomized trials for a variety of acute soft tissue injuries. Physical therapy can improve pain and mobility and facilitate the return to normal function. Massage nerve stimulators, cold initially, then heat applications seem to reduce pain. Manipulation of the cervical spine, such as chiropractic manipulation, is contraindicated in the elderly as well as those with associated neurological abnormalities, osteoporosis, rheumatoid arthritis, and carotid vertebrae atherosclerosis. However, a maneuver test to confirm a cervical injury is Sprain test. In a patient with neck pain or pain that radiates below the elbow, a useful maneuver to further evaluate the cervical spine is Sprain test. Acute low back pain. Back pain is no joke. There's no need to inform you today that back pain is common. Back pain gives no update on when it is coming. Back pain is often recurrent, misunderstood, and mistreated. Moreover, the term sciatica is loosely used for all back pain that radiates, which is theoretically not right, but because the sciatic nerve roots are the most commonly affected, it is coincidentally correct most of the times. Lumbar sprain or strain. Low back pain, also known as low back sprain, lumbar sprain, or lumbar strain, simply refers to an injury to the paravertebral spinal muscles. In acute low back pain, there is an activity intolerance due to back or back leg symptoms of less than 3 months duration, whereas symptoms that persists greater than 3 months is chronic low back pain. Low back pain occurs in nearly 70% of adults at some point in their lives and is one of the most frequent reasons patients seek treatment from a primary care provider. Most cases are self-limiting, but there is a high rate of recurrence. There are two categories of risk factors that influence low back pain: occupational and patient-related. Occupations that require repeated lifting, bending, twisting, prolonged sitting, or motions that cause jarring of the spine, such as horseback riding and jackhammer use, are common culprits. Patients-related factors such as obesity, sedentary lifestyle, weak core muscles, smoking, age, and psychosocial factors such as depression, anxiety, and stress also contribute. Sometimes an inciting event such as cough, sneezing, or exercise can result in low back pain. Low back pain. The history for low back pain is the same as that for neck pain, which was discussed previously, but tailored to the back and legs. Symptoms of low back pain are typically exhibited by diffuse back pain and difficulty with standing erect. Back pain may be accompanied by hip or buttock pain. Pain that is mechanical in nature worsens with activities such as bending, stooping, or twisting, and improves with rest. Stiffness is common. Pain resulting from nerve root compression is termed sciatica and involves radicular pain, or pain that radiates down the leg in a dermatonal pattern. Radicular pain may be continuous or intermittent and tends to wax and wane in intensity. There may be associated numbness and tingling in the dermatome of the nerve root affected or decreased muscle strength in the muscle that are innervated by the nerve root being compressed. It is extremely important to assess for pain that may be related to visceral organs disease such as pyelonephritis, renal calculi, ovarian cyst, pancreatitis, or AAA, aortic abdominal aneurysm. Imaging, not usually indicated in patients with non-specific low back pain. Treatment, conservative treatment for 4 to 6 weeks on NSAIDs. Low back pain physical exam. Physical exam of the low back pain should include the following: range of motion of the lumbar spine, including flexion, extension, and rotation to determine limitation and reproduction of pain. Palpation of the lumbar spine and paraspinal muscles to assess for tenderness and muscle spasms. Palpation of the sciatica notch and hip with testing of hip range of motion. Muscle strength of the lower extremities, including flexor and extensors of the hips, knees, and feet. Tip tendon reflexes. Gait, including heel and toe walking. SLR, straight leg raise test, and sensation should be assessed by paying attention to dermatomal patterns, as this may indicate nerve root compression. Differential diagnosis. Low back pain is a diagnosis of exclusion based on history and compatible physical examination. The differentials include the following: fracture of the vertebrae seen on plain X-ray, HNP or ruptured disc, unilateral or bilateral radicular pain with leg pain greater than back pain, ankylosing spondylitis, drug-seeking behavior, visceral organ disease, cancer with metastasis to spine or spine tumor, spine infection of epidural space. Low back pain treatment. Acute low back pain does not warrant radiographic imaging unless there is evidence of neurological dysfunction, significant trauma, osteoporosis, fever greater than 38.5 for 48 hours or more, suspicion of cancer, or chronic oral steroid use. For chronic low back pain, plain AP and lateral films are appropriate and may show age-related changes such as osteophyte formation and reduced height due to disc degeneration on lateral view. MRI is appropriate after failure of conservative treatment for low back pain with radicular symptoms, or if neurological deficits such as low extremity weakness is observed. Spinal stenosis. A common source of chronic low back pain, seen most with aging, is spinal stenosis. Spinal stenosis is caused by a narrowing of the spinal canal as a result of degeneration of the bony facet, joints, and intervertebral disc. Bone spurs or osteophytes may also grow into the spinal canal. Facet joint become enlarged and arthritic, making less space for the nerve roots. Spinal canal abnormality occurs in virtually every person as they age because the intervertebral disc become worn and continued axial loading over the course of a lifetime leads to arthritis in the spine. The severity of symptoms will depend on the size of the person's spinal canal and the degree of encroachment of the nerves. Spinal stenosis symptoms. In spinal stenosis, leg pain is commonly greater than back pain, and pain is characteristically worse with prolonged standing or walking and improved by rest. In more advanced cases, leg pains with weakness or numbness and tingling can be present. Key questions that can be very revealing in patients with suspected spinal stenosis include the following. When you go to do the groceries, do you find yourself leaning on the cart to minimize your pain? If you're standing in the kitchen doing dishes or cooking, do you lean on the counter for support? If you're walking in the mall, do you find yourself looking for places to sit frequently? So for diagnosis and treatment, imaging plain radiographs should be done to rule out fracture and may reveal facet arthroplasty. MRI is preferable to determine the degree of spinal canal narrowing and facet arthroplasty resulting in nerve impingement. Treatment. Non-surgical treatment may be considered for patients with moderate symptoms, which includes NSAIDs, physical therapy, topical steroids, and EAT. Epidural steroid injection can be suggested to provide short-term symptom relief in some patients with lumbar spinal stenosis and neurogenic radiculopathy. Decompressive lumbar laminectomy is recommended in patients with moderate to severe symptoms of lumbar spinal stenosis who have failed conservative treatment. Lumbar disc herniation. Herniated nucleus propulsus (HNP) is the medical term for what is commonly known as a herniated or slipped disc. Between each bony vertebrae lies a disc that provides cushion, support, and flexibility within the spine. Each disc is named for the vertebrae above and below it. So the disc between the L4 and L5 space is referred to as the L4-L5 disc. The discs are filled with gelatinous substance that is like a cushion sac. As part of the normal aging process, the disc degenerates over time and start to become less absorbent. When a small tear occurs in the disc, the innermost portion of the gel-like substance can ooze out of the disc. Typical pain associated with HNP occurs when the content compress the nerve root on one or both sides. Pain can be mild or debilitating. Lumbar disc herniation history and physical. The history and physical for suspected HNP is the same as for spinal stenosis. Questions regarding acute injury should be asked, as trauma can contribute. Most patients can recall the time when the pain occurred and an inciting event. Some may experience a gradual onset of symptoms. Straight leg test usually produces pain on the affected side between the angle of 30 and 60 degrees. With knee extended, raise leg until pain is reproduced, then slowly lower leg until pain is gone. Provider should ensure the foot is dorsiflexed for testing accuracy. The sensitivity is 91% and the specificity is 26%. Gensling sign. Hip joint is flexed maximally on one side and the opposite hip joint is extended, stressing both sacroiliac joints simultaneously. This test is considered positive if the patient experiences pain while the test is performed. Patrick's maneuver or Faber test. This is a test for the hip or sacroiliac joint. It isolates spasm to the iliopsoas muscle. The provider will flex, abduct, and externally rotate the hip. Pain while completing maneuver is positive. The sensitivity is at 77%, while the specificity is 100%. So, moving on to lumbar disc herniation symptoms. When nerve compression occurs, symptoms typically include the following. Leg pain is more than back pain. Pain that reveals or travels in a dermatonal pattern of the nerve root that is compressed. L1, L3 produces radiation of pain to the hip and or anterior thigh. Numbness, weakness, tingling, and diminished reflexes in the legs. Diagnosis and treatment. Most patients with acute uncomplicated low back pain, i.e. no red flags, do not require imaging. Blood test or other diagnostic tests and 4 to 6 weeks of treatment is appropriate before consideration of imaging studies. In fact, many insurances will deny a request for advanced imaging if failure of conservative treatment is not shown because rapid or routine MRI in the early care of patient increases cost without significantly improving pain or long-term function. In most patients, symptoms of lumbar disc herniation with imaging confirmed neurologic involvement will improve with conservative management alone, which includes oral analgesics, physical therapy, ESIs, and exercises. And here is a color flag system. So for red, these are medical issues that must be diagnosed early and not missed, while the orange, these are serious psychiatric illnesses that will prevent effective pain management. Yellow, these psychobehavioral issues can be addressed by certain members of your pain management team. Blue is perception of occupation is to do with the patient's work status, how they perceive their occupation, while black is actual work conditions. The red in particular as cancer, infection, fracture, Coda equina syndrome, neurology, structural deformity, HIV, and organic pathology. The most important on the red is the Coda equina syndrome, which has to do with bowel and bladder control. Conclusion and pearls. Overall, keeping the plan of care simple and short is key to successful management of musculoskeletal disorders. Approximately 85% of musculoskeletal disorders can be resolved with exercise, stretching, physical therapy, over-the-counter inserts, work restrictions, and proper implementation of ergonomics. The goal is to improve patients' physical function, increase comfort, decrease pain, teach cognitive behavioral therapy, and strengthen main muscle groups. The worst and most harmful treatment that can be provided to patients is bed rest, except in case of fractures. Finally, primary care providers should know their scope of practice and refer in a timely manner for quick recovery to specialties.